Hi everyone, this is Andrea. Chapter 6 is what we'll go over here. So nursing care of patients with fluid, electrolyte, and acid-base imbalances. The objectives that are listed in your slides. Also, you can refer to the beginning first page of chapter 6 in your textbook. They'll be listed there as well as the objectives in your course guide, which is posted in Brightspace under content. It's important when you're reviewing for the exam that you can turn the objectives into questions and that you can answer those appropriately. So just remember that when you're studying for this exam and all of your exams. So we're going to begin by going over solutes. So this PowerPoint really follows your textbook fairly well, so you can kind of refer back. Make sure that you're reading the chapter in its entirety on your own as well, at least once, taking notes and kind of using the information that I give you in the presentation as well as the information in your text so that you have a really good overall understanding of this content. We're going to start out by talking about solutes. Solutes are solid substances that dissolve in a solution. Solid substances that dissolve in a solution. A few examples that I can give you just to help bring this to simple terms would be for those of you that have had children or have ever had to mix up a bottle for a baby that has formula. So in doing that, if we refer to the picture at the bottom of the screen, the solute would be the formula in the powder form. The solvent would be the water that you're mixing with the powder, and mixing that thoroughly together, you get a solution without any clumps of formula left in it. Same thing if you're mixing up like a powder flavor, like a Crystal Light packet or any sort of flavoring in a water bottle. The solute would be the powder that you pour into the water, you mix it together, you get a solution. So that's kind of an example of what we're doing when we mix things into solutions that our patients would receive, whether it's an IV form, there'll be things in the IV bag, but they're mixed so thoroughly in there that it's now a solution rather than if it's not mixed well, it would not be classified as an actual solution. Okay, so the electrolytes that we commonly see mixed into a solution format would be sodium, potassium, calcium, and magnesium. Okay, these are called electrolytes because they can conduct electricity when they're dissolved. So really important for the function of our cells and of our body. We need these electrolytes to properly function. So when we are thinking about this, can you think of any medications that are solutes? So if you think for a minute, any medications that you may have given in clinical or seen given in long-term care that are solutes. The best one that comes to mind is always Miralax. Okay, so Miralax is a powder. You put a capful, or usually about 17.6 grams of powder into 8 ounces of water, mix it thoroughly, and then you create a solution. So that's a good example of a solute that you might use in the clinical setting. A little bit of overall background information, kind of stepping away from this slide, but if you want to make additional notes, the young adult's body is about 60% water. An older adult's body is less than 50% water. So when we're thinking about this dilution that takes place, solutes and solvents and the mixing and the solution that happens, that's going to be a different process for an older adult because they don't have as much solvent. They don't have as much water, okay? So if there's not as much water, then the calculation of how this mixing happens can be a little altered. And if you have questions about that, please let me know. The other thing to keep in mind is that fat cells do not contain water. Fat cells do not contain water. So individuals that have a higher percentage of fat cells have a lower percentage of water, which tends to be why we see individuals with a higher BMI that are more dehydrated, because those fat cells don't have any water reserved for them. So really important things to think about as well. Fluid balance. We have intracellular fluid, that's fluid inside of our actual cells, and extracellular fluid. Within the component of extracellular fluid, we have interstitial fluid. This is water that surrounds the body's cells, and that includes the lymph. Water that surrounds the body's cells, including the lymph. Intravascular fluid, which is fluid, blood, or plasma that is within the arteries, veins, or capillaries. And looking at that word intra, so within vascular, the vascular system. Okay, so the fluid that's in the arteries, veins, and capillaries. Transcellular fluid is within specific compartments of the body. So specifically, especially within our joints. So synovial fluid, which is in a lot of our joints, like our knee joint, our shoulder joint, that fluid, synovial fluid, is specific to that joint. You're not going to find that fluid anywhere else in the body. Cerebrospinal fluid is specific to your spinal cord. You're not going to find cerebrospinal fluid in other areas of your body. You wouldn't find it in your leg or your arm or anything like that. Another example of a transcellular fluid would be like digestive juices in the stomach. You won't find digestive juices somewhere down in your foot. You're only going to find them in your stomach. So just kind of knowing fluid balance as far as where everything is terminology-wise. So a little review question, where are most body fluids found? Take a second to think about that. And the answer is intracellular. So if we flip back to our previous slide, take a peek at that if you're struggling with that question. Control of the fluid balance. This is a pretty important concept to really make sure that you understand. Once you understand it, you'll be smooth sailing. If it's foggy at all, you'll struggle. Okay, so make sure, I'll try to explain this pretty thoroughly, and make sure that you could recite this or teach this to someone else, that you understand it that well, because then you won't get confused. If you just kind of brush over it, you're going to get confused. So antidiuretic hormone, or ADH, the other name for that is vasopressin. Okay, vasopressin. When something is anti, it's going to mean the opposite. Okay, so if somebody was given diuretics, if we look at kind of the key word there, diuretic, we know diuretics are things that help us excrete extra fluid. Okay, so things like Lasix, which is furosemide, those kinds of drugs are diuretics. They help our body get rid of extra fluid. If something is an antidiuretic, it means that it's going to hold on to fluid and not let that fluid escape the body, okay? Specifically here, we're not talking about a medication, we're talking about a hormone that exists in our body, but it's an antidiuretic hormone. So it helps keep fluid on board without diuresing us, as long as it's present in correct amounts, okay? So in our body, we have pressure sensors. They are kind of the control centers of our body. We also have our pituitary gland. The pituitary gland is what releases ADH, that antidiuretic hormone. Diuretics can cause the kidneys to excrete more fluid, okay? But like I said, ADH is the opposite of that. Antidiuretic hormone causes the kidneys to retain fluid, okay? Retain fluid. So if you're taking care of a client that has damage to their pituitary gland and they're not releasing ADH in proper amounts, they will be getting rid of too much fluid. Okay, they'll be getting rid of too much fluid because they aren't producing enough of that antidiuretic hormone to keep that fluid on board. So if we think about this, when someone is hypotensive, so they have a low blood pressure, would more or less ADH be released by the pituitary gland? Okay, somebody is hypotensive. Are they going to release more or less ADH to try to compensate for that? They're going to release more, okay? The body is sensing that in a hypotensive state, usually there's a fluid imbalance. There's not enough fluid on board. And so our body wants to hold on to whatever fluid it can and not release any additional fluid. So more ADH is going to be released by the pituitary gland. When someone is experiencing hypertension, would more or less ADH be released by the pituitary gland? So in this case, there'll be less ADH released, and that will allow the kidneys to eliminate more water. Okay, less ADH means less hormone telling the body to hold on to water, so therefore it will excrete that water through the kidneys. So just take your time on this slide and step by step. Movement of fluids and electrolytes in our body. So fluids and electrolytes can move by active transport through sodium-potassium pumps. These sodium-potassium pumps cause sodium to move out of cells and potassium to move into cells. Okay, sodium to move out of cells, potassium to move into cells. Fluids can also move by passive transport through diffusion. Diffusion is the movement of a substance from an area of high concentration to an area of low concentration. A good example of this would be if we were sitting in our classroom right now and someone was down the hall in the staff lounge making popcorn, and we could start to smell that popcorn down in our classroom. That smell would be diffusing down the hallway. Okay, so that's an example of passive transport, specifically diffusion. Filtration is the movement of water and smaller particles through a semi-permeable membrane. So what can happen in this situation, a good example is like when the heart pushes water and solutes out to the end of capillaries. Okay, when this happens, it's kind of like a screening system that then allows the fluid to return back. Or in very simple terms, think about a strainer and you are draining noodles that you just cooked on the stove, and the noodles don't go through the strainer, but the water does. Okay, passive transport filtration. Osmosis is the movement of water from an area of lower concentration to an area of higher concentration. Remember that water follows salt. Okay, so osmosis, the movement of water from lower concentration to higher concentration. Wherever there is a higher amount of salt, that is where the water is going to tend to go to, because the water wants to mix with that salt to create a solution. Osmolarity and tonicity. This is a slide that's really important in the clinical setting. So for some of you, when you've done case studies for makeup clinical hours, or when you've just been looking at the fluids that are hanging in your client's room and you think, I don't know why they're on that fluid, this is a slide we're going to help explain the why, okay? So osmolarity or tonicity is the concentration of substances in body fluids. Okay, concentration of substances in body fluids. So when we classify fluids, we'll say that a fluid is either isotonic, hypotonic, or hypertonic. Isotonic solutions have the same osmolarity as blood. Okay, same osmolarity as blood. This is the most common solution that we give our clients. The example of this would be 0.9% normal saline solution or lactated ringers. Because isotonic solution has the same osmolarity as blood, that is why normal saline is the only solution that's compatible with blood when someone's getting a blood transfusion. Okay, so that's important in our nursing role. Usually isotonic solutions are used for rehydrating someone, especially someone that's been vomiting, having diarrhea, if they're hemorrhaging. And then always used when giving blood products, always using that 0.9% normal saline. Hypotonic solutions have a lower osmolarity than blood. Lower osmolarity than blood. So these are like 0.45% saline solution, which is half normal saline. Okay, so hopefully you've seen that in clinical, half normal saline. These solutions cause water to leave the blood and extra cellular areas and enter the cell. Okay, causes water to leave the blood and the extracellular fluid and enter the cell. So these are going to push water back into the client cells, push the water back into the client cells. This is used a lot if someone has hypernatremia. Hypernatremia, so they have too high of levels of salt in their blood, or they have diabetic ketoacidosis. Okay, diabetic ketoacidosis. And I know you've probably seen this used for other clients in the clinical setting. It's used a lot on older adults as well, but that's kind of the primary reason for this. Hypertonic solutions have a greater osmotic pressure than blood. So D5 or 5% dextrose solutions are an example of this. These cause water to leave cells and enter the bloodstream and extracellular fluid areas. Okay, so the water is going to come back out of the cells. Sometimes you'll see a combo type solution. So it's D5 half normal saline. So what do you have there? You have water leaving the cells, and then the half normal saline part, you have water entering the cells. So it kind of helps balance each other out. Usually with hypertonic, these solutions are used with diabetic patients who are NPO because they need that little bit of dextrose in their solution to help maintain their blood sugars. It's always these D5 solutions are always avoided in patients that have cardiac failure or renal failure. Okay, unless they're in like a diabetic NPO status. Usually if somebody has cardiac failure or renal failure, we're not going to give them hypertonic solutions. Isotonic dehydration is the most common type of fluid volume deficit. Isotonic dehydration, okay? And remember, isotonic, same osmolarity as blood. So meaning that most cases when individuals are dehydrated, what they need for replacement IV solution is normal saline or lactated ringers. Dextrose solutions, so those D5 solutions, when they're infused, they're called crystalloid solutions, so you may hear that. So identify the tonicity. So if we look at this bag of IV fluids here, and there's a label next to it, it's 0.5% sodium chloride. We know that as half normal saline. So if you look back in your notes, half normal saline, the tonicity of that would be hypotonic. Okay, hypotonic. Fluid losses and gains. When we are in our daily routines, we're going to gain and lose fluid through the activities and things that we do. Okay, we gain fluids through the food that we eat. We gain fluids through the beverages that we drink. We lose fluid in a sensible and insensible way. Okay, sensible fluid loss means that we're aware of this fluid loss. We're aware of this fluid loss. So a good example, we could measure it. We could measure how much fluid comes out of us. Urination is a great example of sensible fluid loss. We're aware of how much water we lose because we can measure the amount of urine that's excreted. Insensible water loss we're not aware of and we can't measure it. Okay, so examples of insensible water loss would be perspiration. So when we're sweating, our respirations, think of when you breathe outside and it's really cold and you can see your breath. What you're seeing is the water droplets that are in your breath. We can't measure that. Okay, that's insensible loss when we breathe, not only in the winter, happens, all year round, but we can see it in the winter. And then also water elimination through feces. We can't measure a solid stool and determine how much water is in there. Older adults are more prone to fluid deficits because they have a diminished thirst reflex, and their kidneys often do not function effectively. So older adults are more at risk to fluid imbalances. Dehydration in your textbook, box 6-1, is very helpful to look at related to dehydration. So with dehydration, we have hypovolemia, which is loss of fluid from the body. When we lose fluid from the body, this decreases our overall blood volume. Decreases our overall blood volume. And if we think back to when we were talking about ADH, antidiuretic hormone, this is getting back to, if we have decreased blood volume, these patients are going to be hypotensive. So somebody that's dehydrated, they're usually going to have a low blood pressure. They're going to be hypotensive. When someone has fluid volume deficit or dehydration, we are going to see changes in their lab values. Okay, we're going to see changes in their lab values. Usually their hemoglobin and their hematocrit will be elevated, but this elevation is skewed because they're dehydrated. So if we see somebody come in with a really high hemoglobin and hematocrit, we aren't thinking, wow, like they just have excellent lab values. We're thinking they might be dehydrated, okay? And as they get replenished with IV fluids, we may see those lab values then drop back down to what's actually their normal range. When someone has fluid volume deficit or they're dehydrated, they're also going to have a high BUN, an elevated BUN, and an elevated urine specific gravity. So those two lab tests are also going to be elevated. As far as fluid overload, when someone's in fluid overload, a lot of times we'll see these clients on a fluid restriction or a sodium restriction. Remember that fluid, water follows salt. So if we decrease their salt, we're going to decrease the amount of water that's moving with that salt as well. When someone has fluid overload, we're going to see usually edema. So in somebody that has cardiac failure, we're going to usually see that dependent edema in their lower extremities. So they'll have swelling and edema in their feet, ankles, legs. Sometimes that edema can go all the way up to their hips. Usually that edema is pretty pitting. Usually when someone's in fluid overload, they're going to be prescribed diuretics to get rid of the extra fluids. So loop diuretics such as furosemide or Lasix. Remember that when furosemide is given, it causes sodium and water to be excreted, but also potassium. So somebody that's receiving furosemide is also going to be receiving potassium supplementation as well. If someone has fluid overload or fluid dehydration, they're going to be on strict I's and O's because we need to monitor how much fluid is going in, how much fluid is coming out. They'll usually be daily weights when they have fluid overload. They'll be given that supplemental potassium if they're getting diuretics that don't spare that potassium. And keeping a really close eye on these individuals as far as your assessment. A lot of times if it's a severe case of fluid overload, you're going to also notice crackles on auscultation, usually bilateral in the lower bases of the lungs. Kind of an in-class activity that I usually do with this is I tend to go over some signs and symptoms of dehydration, nursing interventions, those types of things. What I'm going to do is post that class activity and the key so that you can work on that with this chapter. Sodium imbalances. Hyponatremia would be a deficit of sodium, so less than 135 as far as blood values. Hypernatremia is going to be sodium excess. So serum sodium levels usually are about 135 to 145, just depending on the reference that you use. So that's a really important lab value to just be able to memorize, because that way when you're getting a report and the nurse says that the serum sodium is 129, you know that your patient has hyponatremia or low sodium. And if they would say that the client has a sodium level of 150, then you know they have hypernatremia. In clinical practice, we see hyponatremia much more than we see hyper, and we'll kind of talk about these different disorders here in a little bit. Hyponatremia specifically. So we're going to talk about hyponatremia on this slide. We'll talk about hypernatremia on the next slide. So hyponatremia, low levels of sodium chloride or salt. So sodium is going to be less than 135. That's what we're going to see on our clients' lab values that come back. They could have fluid excess or fluid deficit. So it doesn't necessarily mean that they'll have one or the other, but usually they will have one of these signs. When someone has hyponatremia or low sodium levels, they're going to have mental status changes. So this may be a client that felt fine and now they're confused, or they were fine and now they're kind of disorientated and they can't quite answer questions how they used to, or they don't quite know where they are. You can also see personality changes for someone that has hyponatremia. So a good example of this is knowing your client's baseline. So if somebody comes in and they're acting confused, disorientated, have personality type of changes, we need to not just jump to the conclusion that they have, dementia or some sort of more severe mental health diagnoses. It might just be that their sodium levels are off. So a lot of times family members will say, this is not mom or dad, or this is not how they normally act. And listen to that and look at their lab values, and that might explain some things. And usually when those sodium values correct, then the individuals feel normal again. It's amazing. It's kind of like urinary tract infections. For those of you that work with older adults, when someone has a urinary tract infection and they just act completely different, and then once it's resolved, they act their normal baseline self again. Very similar with hyponatremia, okay? These individuals are very weak. They usually have nausea and vomiting. The signs and symptoms, even though these seem like, oh, these would jump out at me, they can be pretty vague. So they could, mimic other things. If somebody has nausea and vomiting, are we going to think, oh goodness, they have hyponatremia? Not necessarily, okay? Not until we see that lab value come back. Interventions. So what we're going to do for nursing interventions, usually these individuals will get saline IV infusions. We're going to monitor their eyes and nose, monitor their daily weight, restrict fluids because we want to get their sodium levels to rise. We're going to administer diuretics if fluid excess is occurring in addition. And we're going to really worry about our patient's safety. Okay, so if they have altered mental status because of this, they're a really high fall risk. So we need to keep that in mind as nurses and use whatever our hospital facility allows us to do in order to keep them safe, or long-term care, depending on where you're working. At-risk individuals for hyponatremia are individuals that have really high fevers. They engage in strenuous exercise or physical labor, especially if they do that in the heat. So think of like construction workers, marathon runners, individuals that are out in the summer in really high heat values, and then they're doing strenuous exercise on top of that. They're at high risk for hyponatremia. We really need to make sure that when we replace fluids in our body, if we're at risk for hyponatremia, we not only replace the water, but we replace the sodium as well, the electrolyte. So that's why, especially in older adults, but that's why in the summer, athletes are encouraged to drink things like Gatorade, Powerade, those types of electrolyte infused drinks, because they'll not only replace their water, but they'll also replace their electrolytes. Hypernatremia, signs and symptoms. So sodium lab values greater than 145. Individuals with hypernatremia are usually going to be pretty thirsty, and this can be one of the very first signs that we see. So think of hypernatremia, means high levels of sodium in the bloodstream, okay? If you eat a whole bag of potato chips, naturally you feel thirsty because there's so much salt. So if that helps you remember, for individuals that have high blood values of sodium, they're thirsty too, okay, because of so much salt in their bloodstream. These individuals can also have mental status changes. Usually they're a little bit more mild. And instead of being confused, usually these patients are kind of irritable. They might have some mild tremors. They might be a little more agitated, but they could also have those personality type changes as well. Someone with hypernatremia is at risk for seizures. They usually have muscle weakness, especially skeletal muscle weakness. So walking is going to be difficult for them. Respiratory compromise, because we have skeletal muscles that help us breathe. So in our diaphragm, so weakness of those skeletal muscles in the diaphragm are going to cause respiratory compromise, where they can't take as big and deeper breaths because they don't have good control of their diaphragm muscle. Nursing interventions for individuals with hypernatremia: treat the fluid imbalance first. So fluid replacement without sodium, monitor intake and output, monitor their daily weight, administer diuretics, restrict their dietary sodium, so no extra salt. These are going to be your no added salt diets, and treating the cause. Okay. Usually hypernatremia can be the patient receiving too much sodium in their fluids, too much sodium in their diet, or they have bad kidneys and they have renal failure. So they have a buildup of sodium in their body because they can't excrete it. So they may be eating and drinking in a really balanced fashion, but their kidneys don't excrete the sodium properly, so it builds up in their bloodstream. So like I said, no added salt or low sodium diets are very common for these individuals. Potassium imbalances. So potassium is another really important electrolyte. Hypokalemia is the most common deficit. It's more common than hyperkalemia. So hypokalemia, hypo meaning low, kalemia meaning potassium. Low levels of potassium or potassium deficit. Hyperkalemia, high levels of potassium or potassium excess. Normal serum potassium, about 3.5 to 5. Again, those ranges can vary very slightly just depending on where you work and what you use for a reference. Really important to think about potassium imbalances, whether they are hypo or hyper, or either way, any sort of potassium imbalance can lead to cardiac dysrhythmias that can be life-threatening. Okay, so when your client has a potassium level that is not within normal range, you need to be concerned because it could put them at a lot higher risk for cardiac dysrhythmias. Potassium can be depleted from someone that's just done a bowel prep. So if they just did a bowel prep for a colonoscopy, they're at greater risk for potassium levels to be off. Potassium is so important not only for our cardiac muscle, but really all the skeletal and smooth muscle function in our body. So next we'll talk about hypokalemia, and then we'll talk about hyperkalemia. So hypokalemia, signs and symptoms. If somebody has hypokalemia, their serum potassium is going to be less than 3.5. They will have muscle weakness and cramping. So you've heard the phrase, if somebody has cramps in their legs, eat a banana, because bananas are high in potassium. That's where that kind of comes from, just in our everyday life. Shallow respirations, because they have decreased skeletal muscle activity. They can have mental status changes as well, and they're at very high risk for cardiac dysrhythmias and arrest. And that's why up in the right-hand corner, I put a telemetry unit, which is a 5-lead cardiac unit that we can put on our patients in the hospital setting so we can monitor their heart rhythms, because they're at higher risk for cardiac dysrhythmias and arrest if they have hypokalemia. Their pulse often becomes very weak and thready because of the cardiac muscle being depleted of potassium. They usually have orthostatic hypotension. So remember, that's when our patients go from lying to sitting to standing, and their blood pressure drops when they go through those positional changes. Interventions for someone with hypokalemia would be first to treat any underlying causes. So if we know why their potassium's low, figure that out first. Making sure that we're offering potassium-rich foods, administer potassium replacements, patient education of, what foods are potassium rich, what could be causing them to have potassium depletions. When we talk about on the previous slide, I mentioned to you like bowel preps or, diuretics that don't spare potassium, things like that can put people at really high risk. But we also know that sometimes people will go to those extreme measures to lose weight. So, if you have a 25-year-old that's taking diuretics, they could be very hypokalemic. Or if you have a 25-year-old that's doing all these different sorts of cleanses and bowel preps and things like that to try to lose weight, they, as a result, could get really low blood levels of potassium. So dangerous, okay? Usually these individuals will end up in metabolic alkalosis, and we'll talk about that more when we talk about acid-base imbalance. Patients may receive IV potassium. These are often called potassium riders. They're usually 20 milliequivalents of potassium that are given to clients, and they can be given kind of in their own bag, or some of you in the clinical setting have seen that 20 milliequivalent of potassium mixed in their normal IV bag. So that can be that can help these clients as well. Make sure that you verify the potassium level before you give or hang any IV bag that has added potassium in it, because potassium can be a very high-risk drug, especially if it's in that straight rider form. Any patient in the hospital setting that has low potassium is usually on that telemetry heart monitor just because they are such high risk. And then as far as patient education, foods that are really rich in potassium would include things such as sweet potatoes, regular potatoes, yogurt, prune juice, soybeans, bananas. So, knowing how you could educate your client. And I kind of touched on this a little bit already, but just to hit it home, meds that cause loss of potassium are those diuretics such as furosemide, digoxin causes loss of potassium, corticosteroids such as prednisone that can especially be given if somebody has like a bronchitis or inflammation in their airway. Those can cause potassium levels to drop as well. So when we go back to nursing interventions treating the cause, if you knew somebody was just started on corticosteroids because they had inflammation in their lungs, then that would help explain the situation a little bit better. Potassium can also be lost by severe vomiting and diarrhea. GI suctioning will lower potassium levels, or major surgery or hemorrhage can also put our clients at risk for hyperkalemia. All right, next we're going to talk about hyperkalemia. So hyper meaning elevated or high, kalemia meaning potassium. So our clients with high levels of potassium in their bloodstream. So for signs and symptoms, we will see a potassium lab value that is greater than 5. 5 milliequivalents per liter is the measurement that's used. Typically, we do not see hyperkalemia as much as we see hypokalemia in the clinical setting. Usually, if we see hyperkalemia, it is in individuals that have renal impairments. So they have kidneys that don't function as well. It's pretty rare to see hyperkalemia in someone with healthy kidneys unless they would be taking a lot of oral potassium supplements that aren't necessarily ordered. So they're just kind of doing their own supplementation. Other causes of hyperkalemia could be if somebody is overusing salt substitutes. So a lot of times for individuals that may not be able to add salt to their diet, they have a lot of different salt substitutes that can be purchased at the grocery store, and they have high levels of potassium in them. The other cause for someone potentially to come in with hyperkalemia may be excessive use of oral potassium, especially if they stop taking a diuretic, like a diuretic such as furosemide. that needs potassium supplementation with it. So let's say their prescription for furosemide runs out, or they don't have the funds to refill it, or whatever the case may be, but yet they still keep taking their oral potassium. In those cases, we could have a patient develop hyperkalemia. So blood value is going to be greater than 5. We may see in these clients muscle twitching and cramps, diarrhea, low blood pressure, slow, irregular heart rates, definitely at risk for cardiac dysrhythmia and cardiac arrest. So any potassium level that's out of that 3.5 to 5 range, clients are at risk for those dysrhythmias and potential cardiac arrest. Interventions, we're going to make sure that our clients limit dietary potassium. So if they have high blood levels of potassium, they should not be eating a lot of foods that are high in potassium, because that's only going to increase those values or inhibit them from dropping. Hold any potassium supplements. So this would be the potassium oral pills that are given. Administer medications as ordered. Potassium losing diuretics such as furosemide may be ordered. Electrolytes may be ordered. The generic name for that is sodium polystyrene sulfonate. And what that is going to do, it can be given orally or rectally. And what Electrolyte will do is release sodium and absorb potassium. So potassium will therefore be excreted in the feces and out of the body. Insulin with glucose can also be given. What this does, it facilitates movement of potassium back into cells and out of the bloodstream. So that may be given as well. All of these patients with hyperkalemia should be on telemetry for cardiac monitoring. And typically we see these individuals in metabolic acidosis, which we'll talk about when we get to acid-base balance. Calcium imbalances. So we'll talk next about hypokalemia and hyperkalemia. So normal serum calcium levels are about 9 to 11 milligrams per deciliter, or 4.5 to 5.5 milliequivalents per liter. Calcium is really important for proper functioning of cardiac tissues. It's also a mineral that is stored in bones and teeth. So it's very important in our body. For hypocalcemia, which again tends to be these hypo that are a little bit more common, hypocalcemia, we'll kind of work through this slide here. I know there's a lot of information, but we'll kind of talk top to bottom. So hypocalcemia, hypo meaning low levels of calcium, emia in the blood, so low blood levels of calcium. Again, it's going to be less than 9 milligrams per deciliter, or 4.5 milliequivalents per liter. Individuals that are at greatest risk for developing hypocalcemia are postmenopausal women, especially if they are thin or have a lower BMI, they're petite in structure, and they're Caucasian. Those characteristics put individuals at higher risk for developing hypocalcemia. Individuals that have GI disorders, where they don't absorb adequate calcium from their GI system. Specifically, if someone has Crohn's or a chronic inflammatory bowel disease, they are at higher risk for developing hypocalcemia. Signs and symptoms, mental status changes, hyperactive deep tendon reflexes. And the examples of these are the Trousseau's sign and the Chvostek sign, and there are videos of these within the course, so please be sure to watch to know the difference between these two. It's very interesting, and this is something in your nursing assessment that you would be able to recognize. Diarrhea, cardiac dysrhythmias, and cardiac arrest. Interventions, as far as nursing interventions, really important that we treat the cause. So if somebody's been not able to take their calcium supplements, or if they're not eating a diet that's high in calcium, things like that. So increasing dietary calcium, administering medications as ordered. So PO calcium supplements, aluminum hydroxide, which helps bind to phosphate. With PO calcium supplements, it's important that they're given about 1 to 2 hours after a meal because they'll be better absorbed. So just something to kind of keep in mind when you look at your order sets, that it's best to give them 1 to 2 hours after a meal. Going back to the Trousseau and Chvostek sign, those images are also, there's some good reading in your textbook about these different signs as well. Kind of a side note that I just had to add in here. Some of the food sources that are really high in calcium would be fortified cereals. So any sort of breakfast cereal is usually fortified, and they're going to have higher levels of calcium in it. Canned salmon, spinach, yogurt, cheese, milk, so dairy products as well. A lot of times with hypocalcemia, we usually see it diagnosed when someone comes in with a severe fracture. So let's say an older adult falls and they fracture their pelvis, or they fracture their hip, or they fracture a major bone structure where they have to have surgery. When the blood draws are done, at that time, typically we'll tend to see hypocalcemia, which could, over time have led to breakdown and not as healthy of bone, maybe leading to the potential break. So that is probably something you'll see a lot in practice. Hypercalcemia, or high levels of calcium in the blood. Signs and symptoms: calcium blood levels greater than 11 milligrams per deciliter, or 5.5 milliequivalents per liter. These individuals are going to have increased heart rates and higher blood pressures. Also will have skeletal muscle weakness, decreased GI motility. So think of GI motility, if that's decreased, puts them at a higher risk for constipation, and then bowel problems that can happen because of constipation. As far as nursing interventions, really important that fluids are administered. We really want to promote diuresis in these individuals. Administer medications as ordered: furosemide, calcitonin, or hemodialysis if it's severe. So those are kind of the standards for hypercalcemia. Again, we don't see that as much in the clinical setting. We tend to see more hypo, but important to be familiar with both. Magnesium imbalances. So we're going to talk next about hypomagnesemia and hypermagnesemia. Normal serum magnesium is 1.5 to 2.5 milliequivalents per liter. And always remember, when we're talking about magnesium and we're talking about calcium, they work together. So if someone's has abnormal values in one, it's likely that could be transferred to the other as well. So they tend to kind of work as a team. Hypomagnesemia, signs and symptoms. First, let me just kind of back up a second. So hypomagnesemia is often caused by decreased intake or excessive loss of magnesium, which makes sense, okay? Decreased intake, so not consuming it, whether it's in pill form or through our diet, or excessive loss of magnesium. Malnutrition or starvation type diets can put individuals at great risk for this, as well as if someone has severe Crohn's disease, if they take excessive diuretics, and especially alcoholism. Alcoholism tends to have the side effect of decreasing the magnesium levels in the bloodstream. So we tend to see that often on their lab results. Signs and symptoms: magnesium that's less than 1.5 milliequivalents per liter. These individuals are also going to have a positive Trousseau sign and a positive Chvostek sign. So we talked about that with calcium as well. So making sure that in your chapter and in the videos that makes sense to you what those are. Cardiac dysrhythmia and cardiac arrest. As far as interventions, we're going to treat underlying causes. So if we know somebody is starving themselves or not eating a proper diet, obviously getting them back on track with that if we're able. If we know it's alcohol induced, help for those individuals as well. Administer magnesium replacements. So magnesium sulfate can be given intravenously. If someone's getting any sort of IV magnesium, they're also going to be on a cardiac monitor. So really important. And that's just why the rhythm strip is there, just to remind you of the risk of dysrhythmias. And also that if magnesium replacements are given, these individuals need to be monitored. Hypermagnesemia, so excessive levels of magnesium in the blood. Increased intake is often coupled with decreased renal excretion. Okay, so high levels of magnesium in the blood often caused by increased intake. So someone's ingesting or has too much magnesium in their diet, and they're also not getting rid of that extra magnesium from their kidneys. So that's something to think about there. Signs and symptoms: magnesium levels that are greater than 2.5 milliequivalents per liter. Clients will tend to have hypotension. They're very lethargic. They're very drowsy. Skeletal muscle weakness, respiratory failure, cardiac dysrhythmias and arrest. Usually their heart rate is very bradycardic. It's very slow. Interventions: IV fluids, rehydration, administer medications as ordered. Loop diuretics or furosemide is typically given. It's only going to help if the kidneys are functioning properly. So that's important to kind of think about when you're giving furosemide, and then in severe cases, dialysis. So a review question. We have a 64-year-old female patient that has skin tenting, decreased urine output, and is most likely experiencing which fluid or electrolyte disorder? Hypernatremia, hypocalcemia, fluid excess, or dehydration? And after all that talk about electrolytes, all that's really described here is a case of dehydration. Okay, we don't know anything else as far as lab values or anything different. So at this time, I just want you to take a healthy pause, healthy big deep breath in and out. We're going to move into acid-base balance, and I'm going to try not to give you a lot of extra information at this time, because this topic can be hard for students to grasp initially. So I'm going to use this time to kind of just introduce to you what's on the slides. You're going to supplement that by reading your chapter, and then I have some additional activities, and when we do our review, we'll talk about this more. So we'll kind of just finish out by going through acid-base balance just in the information that's in your slides. Okay, so acid-base balance, we're going to talk about pH. So normal pH of the blood is 7.35 to 7.45. Okay, if something is acidic, it tends to fall lower on the pH scale. So looking at that pH scale as a reference, so acidic individuals would have a pH that's less than 7.35, would have a basic pH if they're greater than 7.45. And alkaline and basic can be used interchangeably. Okay, so with an acid or a base, what's really happening at the chemistry level is substances release a hydrogen ion when they're acidic, and they bind to a hydrogen ion when they're basic. Okay, in our body, the acid that we talk about when we're talking about acid-base balance is HCl, or hydrochloric acid, which is predominantly in our stomach. And when we're talking about bases, we're referring to primarily bicarbonate, which is HCO3 minus. So just kind of thinking about those, hopefully that rings a little bit of a bell from A&P, but it's been a little while for some of you. Acid-base control. So before we even talk through this slide, I want you to pay attention to up in the right-hand corner. There's a diagram of the lungs and a diagram of the kidneys, okay, or an image of the lungs and an image of the kidneys. And we'll talk about where that comes into play here in just a second. So when our body is not at a healthy pH level, so that 7.35 to 7.45, it kicks into its own gears to try to correct that pH, because that's the healthy pH that our body needs to function at. So the first thing that will happen is cellular buffers will take action. So cellular buffers will try to soak up extra hydrogen ions in proteins, hemoglobins, bicarbonates, phosphates. If that doesn't work, the first system that kind of comes into play is our lungs. Okay, so respiratory compensation. So if our blood is too acidic, we tend to try to blow off extra carbon dioxide. So if our blood is too acidic, we're going to be trying to blow off extra CO2, and you'll see this in patients that are in distress, okay? If our blood is too alkaline, we try to conserve carbon dioxide through shallow respirations. So if somebody's acidic, they're almost in that hyperventilating type state. If somebody's alkaline, then they aren't taking big, deep breaths. They're kind of just shallow, slow breathing. So that's how the body tries to compensate for abnormalities from a respiratory perspective. From a metabolic perspective, we're always talking about the kidneys when we talk about metabolic. So the kidneys don't really kick into high gear until about 24 to 48 hours after an acid-base balance has occurred, okay? So first, those cellular buffers will try to do their job. That doesn't work. Then our lungs will try to change the way we're breathing to help make our pH in our blood balance back to normal. If that doesn't work, then our kidneys will start in to try to help correct that acid-base imbalance, and we call that metabolic, okay? So that takes 24 to 48 hours. If the blood is too acidic, the kidneys will reabsorb bicarbonate, because bicarbonate is basic, it's alkaline. So if something's too acidic, the body will try to buffer that with bicarb. Okay, if the blood is too alkaline, the kidneys are going to excrete bicarb, because bicarb is basic or alkaline. If we have more of it, it's going to only make the problem worse if we're already in an alkaline type of situation. When you're reading in your textbook and in some of the examples that you may find, practice examples, we'll talk about that later on, we aren't going to get into compensation in this class. So we're just doing straight acid-base problems. If they start talking about compensation, I want you to kind of tune that out for right now. You'll talk about that more as you continue in higher level classes, but right now we're just kind of going at the more basic stage of this. Acid-base imbalances, what lab value has to be drawn to collect blood pH is what's called an ABG. So it's an arterial blood gas. It comes from an artery, okay? Arterial, artery. So this is a very painful blood collection that has to be done by lab or respiratory therapy, who's ever trained in the facility that you're in to collect it. But it has to be taken from an artery. So it's usually the femoral, brachial, or radial artery that are commonly used for that, just depending on individuals' blood flow, and access, things like that. If somebody had both arms amputated below the elbow, then you would not be able to take a radial artery sample. So just think about that a little bit. Acidosis, we're going to talk about respiratory and metabolic, and alkalosis, respiratory and metabolic. So I'm not going to go into any more detail on this slide. Acidosis. So remember, this is blood pH that's less than 7.35. There's a table in your book, 6.4, that's really going to help you kind of put the puzzle together here. Acidosis, we have respiratory acidosis and metabolic acidosis. Remember, respiratory, lungs, metabolic, kidneys. Okay, so respiratory acidosis, if individuals are in that acidotic state, CO2 is not adequately blown off. CO2 is not adequately blown off. Therefore, it gets retained. So this is common for patients to develop this if they have an underlying condition of COPD, if they're in any sort of respiratory distress, or if they have pain or sedative medications on board. Okay. Metabolic acidosis is too much acid in the body or too little bicarb. Remember, because bicarb is going to buffer out when we have too much acid that's present. Individuals that are likely to develop metabolic acidosis are uncontrolled diabetes mellitus, end-stage renal failure, or individuals at risk because they have severe diarrhea or prolonged intestinal suctioning. Okay. If someone has respiratory acidosis, their lung sounds are going to be what we call Kussmauls, Kussmauls, Kussmauls respirations. These are deep and rapid respirations that can only occur in patients with healthy lungs. And I had a link that I tend to show in class, but feel free if you didn't cover these types of respirations in the respiratory unit to just type in Kussmaul's respirations so that you can listen to what those would sound like, because that's what I would do with you in class. Alkalosis. So remember, this is when the pH is above that 7.45. From a respiratory perspective with the lungs, we have excessive loss of CO2 through hyperventilation. Often happens when individuals are anxious or feel fearful, so they're blowing off too much CO2. Treatment for this, treating the underlying cause, trying to help these individuals slow their breathing through pierced lips. A female patient that's giving labor could very easily go into respiratory alkalosis. Somebody that just found out some devastating news could go into respiratory alkalosis. If that's not corrected, remember 24 to 48 hours later, the kidneys are going to kick in and it turns to a metabolic state. So excessive ingestion of bicarbonate. So if somebody takes too many antacids, takes too much extra baking soda as a bicarb, they could put themselves in metabolic alkalosis, prolonged vomiting or gastric suctioning, and we are going to treat the underlying cause. So if we know that somebody is taking rolls of antacids every day, and that's what's putting them in metabolic alkalosis, then we're going to educate and help that individual stop doing that. If we know it's from prolonged gastric suctioning, we may see different order sets so that that is changed. So kind of think about that. When somebody's hyperventilating, so if somebody's in respiratory alkalosis, the respirations are shallow and the patient can become kind of lightheaded or confused because they're not perfusing oxygen well down to the bases of their lungs. They're really shallow breathing. So there's not good oxygenation that's happening. And so with that, your patient might say that they feel lightheaded or confused and have them sit or lie down. Heart rate's also going to increase and their pulse is going to become weak and thready when they're in an alkalosis type of state. Analyzing ABGs. So this is something that we will do as an activity for this class, but also something that you will be responsible for as far as when it comes exam time, or be able to do this in the clinical setting. Okay. So there is a video that is posted, and I'll talk about that just a little bit more on the next slide as well, but it's awesome to explain how to do this. I show this in class to kind of introduce this concept because it's really kind of out there if you've never done it before, and it just takes a lot of practice. So let me just kind of go through this slide and then we'll go from there. So analyzing ABGs, remember those are arterial blood gases. Those are going to tell us if our blood is acidic or basic, acidic or alkaline, if it's out of that normal pH range. Okay, so the first thing we need to think about when we're analyzing arterial blood gas results is the pH low or is the pH high? And if we look over to the right-hand side, we'd see a reminder that normal pH is 7.35 to 7.45, okay? So if the pH is low, if it's below 7.35, it's acidic. If it's high, if it's above 7.45, it's considered alkalosis or basic. Step 2 is we're going to check our bicarbonate levels. Okay, our HCO3, and bicarbonate is going to act as a base and kind of buffer. So if bicarbonate levels are elevated, we tend to be in a metabolic alkalosis state. If they're low, we tend to be in a metabolic acidosis state. Normal bicarbonate levels are 22 to 26. And the third step we're going to do is check our PCO2 levels. So normal PCO2 levels are 35 to 45 millimeters of mercury. They'll be elevated for somebody that has respiratory acidosis. They're going to be decreased or low for somebody that's in respiratory alkalosis. Okay, you have to be able to memorize the normals. So what's normal pH range, normal bicarb range, normal CO2, PCO2 range, and you'll get a lot of practice with that when we do our problems. Analyzing ABGs, it's called the ABG tic-tac-toe method, and that's the video that's posted under your content that you need to watch, okay? When she starts talking about compensation and uncompensated and that kind of terminology, you can almost kind of tune that out because we're not going to do that in this class, but just the simple solving of ABG problems is something that we're going to do. So please, the link is there for you, but there's also the link in Brightspace. So please watch this video. All right, so that concludes chapter 6. A lot of information, break it down, and we will do some more review of key concepts in a condensed version when we do our review to get ready for the exam.